Welcome to Virtue Podcast, powered by Azkka Pharmaceuticals, India's first company to bring evidence-based flat pricing in medicine. Virtue Podcast brings in renowned healthcare experts as we explore the path to healthier living, where science meets virtuosity. Tune in to YouTube, Instagram, Facebook, and Spotify as we welcome our virtuous guest. Don't forget to subscribe, hit the bell icon for the latest updates, and leave your comments.
Welcome to the Virtue Podcast series, where we decode the secrets of well-being with experts who truly care. I'm Bhavin Bhatt, and today we have with us a name that resonates with credibility and compassion in the field of medicine, Dr. Suhas Erande.
Hello.
With over 35 years of clinical excellence, Dr. Erande is not just a senior physician and a diabetologist, but also an ICMR research fellow and a leader in both clinical trials and patient advocacy. He is the founder of Azkka Diabetes Center and Insulin Pump Clinic in Pune. He has worked across the spectrum from juvenile diabetes to insulin therapy, from the adoption of continuous glucose monitoring to lifestyle disease education. A recognized voice in public health, supported over 1,000 children with type 1 diabetes through structured community programs. It's our privilege to welcome a clinician, educator, and a change maker. Welcome, Dr. Suhas, to the Virtue Podcast series. It's our pleasure to have you, sir.
Thank you so much for such a very elaborate arrangement, and I'm looking forward to talking to you.
It's our pleasure to have you, sir. So, sir, before we dive into today's discussion, allow me to begin with something a bit more personal. We all grew up with vivid dreams, and whether as a pilot or an army officer or as a doctor, these early aspirations often reflect our purest hopes and world we have imagined for ourselves at one point in time. So to open today's conversation with a touch of nostalgia and some introspection, may I ask what was your childhood dream, and how has the life unfolded for you? Did that dream evolve into a remarkable journey that you have taken today, or did destiny lead you somewhere completely which was unexpected?
Yeah, very good initial, I would say, opener. See, this was very, you can say, clear cut. Okay, in the sense I never was supposed to decide what I will be, because the whole credit, technically speaking, is to my grandparents. My grandmother in particular, she always aspired and she always was very ambitious. She wanted her grandson to be a big doctor. Followed by, of course, my own parents, who also certainly aligned with the same thought.
Right.
And that whatever they say, that if somebody aspires, then the whole universe starts backing.
Right.
So to share with the audience, very interestingly, I am a very avid sportsman.
Okay.
You may not really believe that.
Right.
But I had been on a university and state platforms for two very fond games for me. One is Kho-Kho and other is water polo.
Wow.
So my opponents, to tell you the truth, my opponents and of course my teachers on the sports front as well as in the academic front, they also always instilled the values of becoming a doctor. For as far as I was concerned, my opponents used to call me a doctor.
Oh, is it?
Right from my age of 10.
Okay.
So I had no choice, technically speaking, but to follow medicine. Of course, I followed with a real interest and real, I would say, sincerity. And that's where you are.
Right. So I would say, as I understand, I mean, for sure, I mean, to become a doctor and to have such a remarkable career so far and having impacted so many lives over the years, I'm sure there are not one but many forces, as you rightly mentioned, which has a role to play. So I think very inspiring, sir. So, sir, so staying with the same nostalgia, let's step into our conversation. So you have been practicing for over 35 years in the field of diabetes. What initially drew you to that specialty, and what has kept you so deeply committed uh, for all these decades that you have been working?
This is again something which was drafted for me. The drafted word is very important.
Okay.
By the Almighty, I would say.
Right.
I have a very poor handwriting. Okay, a typical doctor's handwriting. And I remember my even primary school teachers, my parents, and everybody around. They tried to really improve my handwriting with earnest efforts. I also put in serious efforts, but to no avail. So my hand skills were always a question of you can say importance, and it was a point of worrying for most of my seniors. So God had decided that this is one person whose hand skills are poor, but He fortunately bestowed a lot of other virtues in me. So I was never meant to be a surgeon. Okay, so naturally that was a default physician which I was, and took fondness to medicine right from the word go, the day I entered my medical school. And diabetes is something which kept happening as I went ahead from my undergraduation to the post-graduation, and it was a stroke of luck, so to say, coincidence you can say, that Sassoon Hospital, where I got educated for my medicine. Sassoon Hospital was a big center of diabetes, any which way. We had a huge, well-defined and well-disciplined diabetic clinic, which was being run for more than 20 years at least when I stepped into that clinic. And then the Indian Council of Medical Research, which had a huge project, which was 9 centers across the country, and all big centers, Chennai, Delhi, Madras, etc. Mumbai, of course, was there. And Sassoon was selected. And that was really, you can say, something which is a coincidence when I was in charge of diabetic clinic, and the center got selected, whatever you say, for the ICMR research project. And then I came into contact with the pioneer of diabetes and endocrinology, Professor M.M.S. Ahuja. He was the head of the department endocrine from All India Institute of Medical Sciences. And he automatically became my mentor and my guide and everything. Everything. So ABCD of diabetes, I was lucky, blessed I would say, got training from right under none other than Dr. M.M.S. Ahuja, who actually is known across the country mainly for being a founder of what is called as Research Society for Study of Diabetes in India, short formed as RSSDI. Unfortunately, sir is no more with us, but he taught diabetes. He instilled the whole interest in the field of diabetes as far as I am concerned.
Wow, that's very inspiring, sir. So that kind of foresight and dedication sets the foundation for the impact that is created in all these years.
Absolutely.
So as you sir rightly mentioned that you were also an ICMR research fellow in diabetes long before it became a major epidemic in India, diabetes as a disease.
Absolutely. 83, 84, 85 was my ICMR duration, and that was a time when the prevalence of diabetes in the country was hardly 6% in the urban area and 1.5 to 2% in the rural areas. Now you can easily multiply that by at least 3, if not 4.
Absolutely. So sir, what drew you to this specialty so early in the career?
Yeah, I have actually told you that I was stuck to medicine by various reasons, and diabetes is an important part of medicine, though not as you can say hugely spreading across the medicine as it is today, but still it was very important. The institute where I was doing my post-graduation always was very keen on diabetology. So that took me, you can say, as a natural force to diabetes. And then because of Professor Ahuja, I got absolutely stuck into diabetes. Very important.
So you have seen diabetes evolve from a very slow pace to rising as an epidemic, and especially in younger populations. So caring for children with diabetes comes with its own emotional and clinical challenges. So from your experience with over 1,000 juvenile diabetes cases that you have handled, so what stands out the most in these kids adapt, and what hurdles do families often struggle with?
Technically, type 1 diabetes or juvenile diabetes is a plethora of problems, and which
Right.
chiefly are not related to diabetes or medicine. They are circumstantial.
Right.
So the emotional aspect, socio-economic aspects, the family which is wrapped up with this diabetes, the family support, the parallel family support. So the apart from the mother and the father of the kid, the other seniors in the family, the teachers, school teachers, the peers, everybody comes in picture. And to say the least, actually the counselors, the state itself, everything comes into picture, because this is a boy or a girl who is going to be with this problem all his life. There is
Right.
no shortcut. There is nothing like a cure of type 1 diabetes as of now.
Hmm.
So the important aspect here is we have to primarily see to it that the fact sinks in. The psychology, the deeds of the boy or a girl, the parents chiefly, and the whole family, the school teachers, the peers, everybody has to really appreciate, understand, and take into their lives that yes, this is a kid who is like this, and there should be nothing like shying away from taking insulin in the classroom, or maybe if the boy or a girl goes into low sugar, then immediately somebody should help.
Right.
And the whole life which is wrapped, which is engrossed with the issue of sugars, they have to really take into their day-to-day living. There are lots of parents who technically are stressed. We have seen parents undergoing counseling
Oh, okay.
because their kids are type 1.
Hmm.
Initially, they may, you can say, take the blame on themselves, because I have some problem, that's why my kid has got a type 1 diabetes. There are parental disputes,
Yeah.
okay, to the tune that there could be divorces
Oh.
in the father and mother.
Oh.
So type 1 diabetes is far more serious from the non-medical aspects,
Right.
equally if not more than the medical or the endocrinology aspects.
True.
Lot of these kids take, you can say, we have to handhold them, and that hand holding continues all the time.
Very true.
So we have lot of boys and girls who have actually now married, but they still actually will come and they will touch my feet according to our culture. And we also have to take a lot of interest into their day-to-day
Right.
evolution in life, their school academic career, even their employees employment career, or their further academic progresses. These kids are in contact from across the globe now.
Right.
So we have to have, they have to have me or the whole diabetes team on their board, and we have to have them on our board all the time. That is the essence, because that disease never goes.
Right.
Okay, we have a good progress in insulins, we have good progress in the injection devices, we have insulin pumps, we have very advanced glucose monitoring devices, automatic insulin pumps which decide on their own how much insulin to be injected,
Right.
whether the insulin is not to be given. All those things are possible, but they come with expenses.
True.
And the patient needs to have some amount of, you can say, in fact, large amount of technology training. So again, we have to handhold them.
Very true.
So the team goes not only from diabetes or medicine aspect, which is me, but we constantly have what is called as a medical social worker. Right from my ICMR days, we have been with a social worker. We have our biochemist, we have our psychological aspect handled. So we have adolescent psychologist also, because these boys and girls, they will undergo lot of age changes, and with advanced age, the body image feelings change. They need different kind of help.
True.
And they need to be taken into account, so to say. And I will categorically mention one juvenile diabetes research foundation, which is run in on a very regular basis in Mumbai, and we take significant help and you can say support from JDRF, because this is one where the kids automatically have their own world. Everybody there is a type 1 diabetes.
Okay.
So they don't feel unfamiliar.
Right.
And that is a very big support group for them today, tomorrow, and maybe even their future lives.
Absolutely.
So these things are very important. We take training, and not only, you can say, an ordinary training, but McKinsey is involved
Right.
in group trainings for the kids their mothers separately, their fathers separately, then
Hmm.
together, then
Right.
maybe their grandparents, their school teachers, their peers, everybody. So this McKinsey thing also goes on maybe at least twice or 4 times in a year. So
Right.
it's a continued process.
True. True.
Continued process all the time.
Absolutely. So, sir, what I understand from what you elaborated and very rightly said, I'm sure this will help a lot of our viewers and patients at large. The first step is the acceptance of the condition itself, I think,
Absolutely.
which is
Absolutely. Yes,
uh,
yes. Because if that is not done, type 1 diabetes is not something which will stay quiet.
hmm,
Okay, like type 2, it can stay quiet. But
right.
type 1 never keeps quiet. If
True.
the kid doesn't take insulin, then the sugar will go up, it will get into poison, what is called as ketoacidosis, the kid has to be admitted.
Right.
So there is no, you can say, escaping
Right.
taking
Right.
insulin. Very important.
So first is acceptance, and second, as this makes me more curious. So I would like to ask that many patients delay starting insulin out of fear, not only per se type 1 but even type 2. So thinking it's a last resort or even a failure. So there are a lot of myths in and around the whole insulin thing. So what would you say to those struggling with this mental barrier, I would say?
True. Now let me clarify here. I just now told that type 1 insulin delaying, no, nobody
Right.
can delay insulin. The type 1 will compel the patient to take insulin.
Absolutely.
This way or the other.
Very true.
Now delaying insulin, it is possible for type 2 diabetes. So
Hmm.
adult diabetes. Type 2 is adult, and therein we feel that probably the lifestyle has a role, then tablets have a role, oral medication, and then if tablets are not containing the sugars, then the doctor thinks of a insulin.
Right.
The important point is insulin is an injection,
Hmm.
and injection is something which deters any human being from taking it.
Right.
And this is not only maybe vaccination, you take it and go away. No, it has to be there. It has to be there at least once a day, maybe more number of times a day. Now with advanced insulins now, let me declare here that soon we will be having once a week insulin,
Wow.
which will be there. So there are, you can say, all the time progresses
Research
from
and
science
progress.
aspect.
Right.
However, it is injection. So the first reaction of the patient is, I will not take it. Try, doctor, give me some different tablets. Let us try. I will do more diet, discipline, etc.
Right.
But there are situations like maybe somebody meets with a heart attack or paralysis, some severe infection. He has to undergo an operation. He is hospitalized for whatever reason. And that is a time when we give insulin. Now,
Right.
that is a time when the patient has no choice.
True.
So we give multiple insulin injections sometimes. But the patient can't complain because his attention is towards the operation
Right.
or for the reason for which he is hospitalized.
True.
But the same patient, when he is discharged, he will be asked to take insulin. And that is the one situation where the patient automatically takes insulin. So that injection, fear, reservations, they don't apply there. Same about the girls who get pregnant. Either they are diabetic getting pregnant or their diabetes is detected for the first time when they have got pregnant.
Right.
And the only medication allowed in pregnancy for most of the cases is insulin.
Absolutely.
But there also they don't say no.
Right.
None of my gestational diabetes or pregnant diabetic ladies, women or girls, nobody has rejected insulin.
True.
Because their attention is towards the safe delivery,
Very
etc.
true. So the focus is a larger
focus
goal,
is different. So there is nothing like rejection.
True.
The important thing, the family also ropes in. So there is a huge support from the family, because in our culture, any girl getting pregnant, the parents, the in-laws, everybody is involved. So there is a huge support also. So taken into this consideration, the important point is insulin injection is a relative phenomenon. It's a question of time. If somebody is already taking injection in the family, then the reservation can be sometimes actually a bit lesser.
Absolutely.
Right?
Very true.
Very important. Some friends, some colleague in the office, or somebody who is known to me is
Right.
taking injection. So there is the fear element is less.
So they have seen and they know
They have
that
seen,
it's
yes.
something
They
which
have
is
seen
very
and they know that this is
regular.
nothing very extraordinary,
Very true.
very demanding.
Right.
And these days the injection devices are so patient friendly, extremely patient friendly. There is hardly any pain when you inject the insulin. Very important.
True.
And from our side, what we try to do, we have dummies. Okay, so we demonstrate how to take the insulin.
Right.
We actually have distilled water injections. So we take injection. I show the injection here or here that way. So the fear element is, you can say, reduced. We actually, as a, you can say, strategy, what I have been doing is, when the patient of type 2 adult diabetes, when they get diagnosed, where they are to be started on diet, discipline, exercise and tablets, that is a time when I start discussing insulin.
Right.
So insulin is not prescribed. Insulin is not to be given also. The patient may not require insulin all his lifetime.
But they are mentally prepared.
They are taught. Okay,
Right.
we teach diabetics. See, diabetes is an issue of education.
Very true.
And it was one of our very senior professors, Professor Eliot Jocelyn, who has a very famous, world famous Jocelyn clinic in US. And he used to say that diabetes is a matter of education. In fact, Professor Ahuja, my own teacher, he always insisted that diabetes is a matter of education. To you, to your colleagues, to your team, to your patients, and whosoever is involved in diabetes. And that is so true even as of today.
Right.
Because I can always admit here that I study at least 2 hours per day, sometimes 6 hours. Yesterday I was reading for 6 hours.
Wow.
It was a Sunday. I have to do that because I have to handle lots of patients who have peculiar problems related to diabetes or related to diabetes and some medical problems.
Absolutely.
So we have to do all these things. We teach the patients. So psychologically we advise them. We psychologically prepare them. If at all they require insulin down the line, maybe.
Right.
I call we have some sessions which are called as insulin teaching sessions. Now we will be starting every other month. We will start this month and that will go on every other month. So July and then September, that way. And these are of course kids who have been registered, and they will be shown how to take injection, the correct technique, the disposal of the insulin syringes, the needles, care of the injection site, lot of things. Because if they go wrong there, then the problems will actually spiral up.
True.
So that teaching is very important so that the patients have less fear of insulin. And for a lot of people, what we do is we ask them to come to our center, inject, they go back.
Right.
Next day again they come, they go back.
Right.
Not everybody can do it,
True.
but we try to do that if it is feasible. And then on maybe a 5th or 6th day, we ask them, now you inject yourself.
Right.
I am there.
True.
So their confidence level is
Handholding
very
process
good,
is,
and it is supervised to be correct.
Very true. Very
Right?
true.
So the injection of insulin becomes very, you can say, no apprehension is there. They know that my doctor is by my side, and then they start taking on their own.
Very true.
We always tell them that if you take insulin in time, you may not require insulin for your lifetime. That's a very important thing. I am somebody who is very aggressively into trials, as you have mentioned.
Right.
So we have used insulin right on the day of diagnosis of type 2 diabetes, not type 1, type 2 diabetes.
Right.
We have used insulin till the time their sugars are good, not only good but very good, and then we have stopped insulin.
Right.
So these are the patients with whom our other patients also mingle and interact.
Right.
So they know that there are lot of people in my clinic who have used insulin, but down the line they are on tablets.
Right.
So the statement gets boosted. Use insulin in time so that you don't have to use it lifetime.
Right.
So these philosophies certainly work.
True.
We have some small booklets also which we distribute to all patients.
Right.
Okay, all patients. Not necessarily one who is taking insulin, but any diabetic patient. So that makes the matter very comfortable.
True.
Challenges remain, I tell you. Challenges
Absolutely.
remain. But let me add again here on this platform that compared to some tablets now, some tablets these days are quite costly.
Right.
They are new tablets, so their patents are still on, so they are costly.
Right.
But some insulins are now even more affordable compared to
Then the
these tablets.
Ah,
So something which is very easier on the pocket, most of the patients can treat.
right.
And there are a lot of, you can say, arrangements, facilities wherein the patients can get insulin at concession or maybe even free of charge. Lot of pharma companies help us to give free insulin to quite a few of our type 1 diabetics. So that makes the matter that much feasible.
So, sir, what I gather from what you said is it's more about educating about diabetes.
Absolutely.
Which is,
Absolutely.
the
Education never
foundation,
ends. Yes.
to ensure that the condition is managed well in longer run.
Yeah.
So first it starts from the acceptance to make sure that the patients and the family accept it.
Yeah.
And
then
then
they stick to it.
Absolutely. So I think diabetes education, what you said, is absolutely
See, our
very
motto,
important.
I will tell you, our motto, which will run through our discussion. If diabetes is relentless, I have to be relentless.
Very true.
And then naturally my patients also need to be
Absolutely,
relentless.
absolutely.
Yeah.
So it's a joint effort by the
Absolutely,
clinician,
yes.
the family,
Yes,
and the
yes.
patient itself. So, sir, so this gives me a clue to ask you something, that in long-term diabetes, do you, in your clinical setup, do you prefer insulin initiation or aggressive oral drug combinations first? And what's the smarter move today?
Yeah. Actually speaking, there is a fair amount of clear-cut guidelines from some world authorities like American Diabetic Association, International Diabetes Federation, or our own RSCDI, India RSCDI. So we have our own guidelines also.
Right.
On a very, let's say, large scale, or on a typical garden variety of the patient, he starts on a tablets.
Okay.
Okay, he starts on tablets, lifestyle, diet, discipline, exercise. If he is overweight, obese, he has to do exercise to reduce weight, all these things. And then if more than generally 3 or sometimes 4 tablets, different drugs, if they are not successful in controlling the sugars, and control of sugar is defined by 2 criteria: fasting sugar, postprandial sugar, around 100 and 140, HbA1c, which is the 3 months average of the sugar control, less than 7%.
Right.
Most of the patients, if they are able to attain this, we continue the tablets.
Right.
If they are not, then that probably means that the pancreas is now exhausted, not responding to the tablets mostly, and probably the patient has to be shortlisted for possibility of taking an insulin.
So, sir,
It's a guideline kind of thing, but we have to use our discretion. As I told you, the patient is to undergo operation, the patient is rapidly losing weight, having lot of thirst, lot of urination, we call it as catabolic symptoms or osmotic symptoms. Then we don't wait, we expedite or start using insulin urgently.
Right.
Pregnancy, we start using insulin immediately.
True.
So these are the things which are exception, where our discretion needs to be there. Especially infections, we have to use insulin lot of times, maybe for some period of time.
Right.
However, in a typical patient, tablets, 3 or 4 types of tablets, full doses of the tablets, HbA1c is still more than 8.5, our guidelines say that think of insulin.
Okay.
And that's the way we take the patient to insulin. Exceptional. There are some patients who are extremely health aware, and they not only want their HbA1c 7, but they want it to be more, let's say, close to normal. So 6.5, the associations say that even if you are able to take the patient to 6%, which is a very stringent or tight control, if the patient is aware, the patient is, you can say, in tandem with you, and continuously communication, so continuous glucometer use, repeated sugar readings, patient feeds us with those readings, we react on that. If that is a close-knit circuit, we can take the patients to a very stringent control also by using insulin.
Right.
There are quite a few doctor patients who insist on insulin.
Right.
Okay, they don't want tablets because insulin, all said and done, forget that injection, etc. Insulin has only 2 side effects. Number 1, it can make the patient gain weight, though not relentlessly, but it can make the patient gain weight. Insulin is an anabolic hormone. It increases the appetite.
True.
Patient is hungry. And 2, if the dose is more compared to what you have eaten, the sugar can go low, hypoglycemia.
Right.
So to clip this, there are newer insulins which make the patient put on weight, not huge, but very little amount of weight. And 2, if the patient is monitoring, then and giving me a feedback, then we are always on the trail of low sugar.
Okay.
And we teach them how not to go into the hypoglycemia, what are the precautions, what are the warning symptoms of low sugars. So the patients can successfully use multi-dose insulin or pumps in tandem with us in a good backbone of glucose monitoring, and they can always succeed in having a very good control. So that depends on the circumstances. Diabetes dictates the story. The real orchestra is played by diabetes.
Right.
I am, at the most, I would say, I am somebody who can do all that. Okay, I am not a. The orchestra is actually run by diabetes.
Right.
The patient has to play the right, you can say, instruments.
True.
The symphony has to be maintained.
Very true.
Then the story is successful.
Very true. So, sir, I think here also adherence to the therapy also would be a critical thing that comes into play, because as you said, when oral diabetics become maybe say 3 or 4 plus tablets, adherence itself can be a big issue which may not be able to help controlling
You
the diabetes.
absolutely hit the right point.
Mm.
Because I told you diabetes is relentless, means
Mm.
that the patient needs to be, you can say, vigilant. I
Right.
need to be vigilant
Mm.
all the time. So it can't be that I have not checked my sugar for 4 or 5 months because I don't have a complaint. Okay, I have stopped the tablet because my report was good,
Mm.
and the laboratory has really given a remark that this is you can say very good control.
Mm.
Laboratories certainly have very good control remark.
Mm.
So if the patient gets very happy because of that, if he stops the tablets, if
Mm.
he stops the discipline, then diabetes is a villain.
Mm.
Diabetes is bound to be, you can say, come back.
Right.
So adherence is very important.
Mm.
Whatever regularity we have said, the World Associations RSADI tells that the patient needs to be seen by you at least 4 times in a year. So 3 months the patient needs to come to me.
Right.
Sugar, blood pressure, weight, whatever his day-to-day observations, plus minus in the diet, discipline, whatever.
Mm.
He has to talk to our dietitian. He has to talk to maybe our exercise group.
Mm.
All these things are necessary. Tablets is not the be and end of everything. There are
Right.
quite a few who are managed on maybe a single tablet or maybe on lifestyle.
True.
But they can't afford to be carefree also.
Very true.
Okay,
Very
forget careless.
Mm.
They have to be watchful,
Mm.
and then the story can be really told to be successful, and the success can be maintained over a period of time. That is extremely important. So adherence, no concession there.
Absolutely. So, sir, we often hear, so taking a clue from what you said earlier, that we often hear 6.5 or 7 as a gold standard for HbA1c. But should that number be the same for everyone? And how do you personalize HbA1c goals in real practice?
Okay, there are two parts of my answer now.
Mm-hmm.
Well, yes, 7, 6.5, even I mentioned 6. This is something which depends on the patient.
Right.
Whether the patient is newly diagnosed or he is a long-standing diabetes, whether he is young or old, whether he stays in a family or whether he stays alone, whether he is gadget savvy, can operate the glucometer or maybe the continuous glucose monitor, can give me a feedback, or my team needs to be kept in the loop. Can he do it? Is he tech savvy? And then whether he has complications. See, diabetes is a story which is defined by sugar.
Right.
But diabetes is not a story which ends by the sugar. Absolutely. Mostly it ends by some problems.
Absolutely.
Which are heart attacks, paralysis, amputation of the toes or limbs, kidney failure, blindness, so on and so forth.
Absolutely.
So diabetes is not only HbA1c. If the patient has heart problem, if the patient has kidney problem, or maybe liver problems these days. So if that is the situation, then we are cautious. We don't insist on a very stringent control. For example, if a person is old, staying alone, and if he goes into a low sugar, then who will be there to help him? He might remain in low sugar and he might have some more problems related to brain. We don't want that. So there are situations where probably going a bit conservative is advised. So old man, long-standing diabetes, kidney problem, already undergone maybe a bypass or a angioplasty, poor vision, can't maybe do the glucometers or the continuous glucose monitors frequently, can't be in loop with me all the time. We are conservative. We say that, okay, your HbA1c, even if it is 7.5, don't bother. There are some patients who are admitted, long-term care, or maybe old age homes. So there we say that, okay, your HbA1c, even if it is 8, don't worry. We have to look at the expected lifespan of the patient. Somebody who is 18-year-old, I have to be very strict because he has to live his life.
Absolutely.
Somebody who is 80 years, the expected lifespan is less. So we don't actually stick to that 7.
Right.
We say that it's okay. 8 also is all right. Hypoglycemia can be of more danger than maybe a stringent control benefit. So we have to balance it out and then decide about it. Right. Other part of the answer, if you really ask me, I have to see to it that I don't get led by HbA1c. I get led by ABC. A is HbA1c, sugar control, B is blood pressure, C is cholesterol.
Right.
So these are the things which are actually every diabetic, we teach them to be ABC oriented.
Right.
So don't be, you can say, if somebody is diabetic today, down the line, there is a higher chance that he might develop high blood pressure.
True.
Higher chance that he might develop high cholesterol. And that can be more of a problem. I have written a patient education book 25 years ago. It is in Marathi. मधुमेह आणि हृदयविकार. मधुमेह हाच हृदयविकार. Okay, so I have instilled in my patients also that don't be, you can say, under impression that diabetes is only sugar. Diabetes technically is a problem of circulation.
True.
Because more than 3/4 of our diabetic patients, they die of circulatory problems. Be it heart attack, paralysis, or be it amputation of the toes. All are circulatory problems. So I want the patients to be ABC centric.
Right.
Naturally, my team is also ABC centric.
Right.
Periodically, we have to screen their kidney function, whether they are losing proteins in the kidney. At least once in a year, we have to look at the fundus, the retina of the patient, the pulses of the foot, the spaces in between the toes. All these things are necessary. These days, the list is actually added by fatty liver. So we have to screen the patients for fatty liver. Quite a few are obese, overweight. At least they have central obesity, so pot belly kind of thing. We have to be cautious about these things. Because the killers may not be, you can say, coming right from the front. Diabetes is always a backstabber. Blood pressure is a backstabber. Cholesterol is a backstabber. No notice. Patient can be very, very comfortable, very, very happy, leading his life absolutely normally. But he can suddenly collapse. And then we realize that all his heart arteries are blocked. That's a very poor scenario. We have to be cautious. We have to be on the trail of these problems rather than maybe chase them after the complications.
True. So we got to be very vigilant, and a holistic approach helps.
Absolutely.
In this. Right. So, sir, do you think that tools like continuous glucose monitoring should be reserved for complex cases, or can even average patients benefit from real-time glucose insights?
There are two issues which we need to really appreciate here. The continuous glucose monitoring system has, on a large or on a crude scale, it has the advantage that a patient doesn't have to keep on pricking his fingers.
Right.
So some kind of pain is, you can say, averted, and some kind of convenience is there. Number two, the frequency of monitoring. Glucometer, how many times can we really do? 4 times, 5 times. Our disciplined patients can be asked to do it 7 times.
Right.
But it's very cumbersome.
Absolutely.
So the continuous glucose monitoring, depending on which category we are using, it can give us a reading every 15 minutes, every 10 minutes, every 5 minutes. Now we have every minute sensors also. And the things can be downloaded on your smartphone. You can always send the readings to me.
Right.
If you really are very keen, I can always show you the show which is always going on. As far as my patients are concerned, the important point to be appreciated here is continuous glucose monitoring primarily will be done for a patient where low sugar is more of a problem.
Right.
So the patients are chasing the sugars, and if I or the patient, they appreciate that, see, that is the way our patients are all the time sending the sugars, and I am advising them on insulin doses, so on and so forth.
Right.
This is primarily meant to avoid low sugars.
Very true.
Be very clear.
Very true.
CGM is not for good control. CGM is primarily to avoid hypoglycemia.
Right.
Next is something where the patients can be advised. They send the readings, or I am in the circuit, so I always keep on sending the advice on insulin dose, all these things. But the patient has to be more sincere, committed to a good sugar control.
Very
Otherwise, no, I will go to the lab once in 3 months, I will bring the reports to you. So that's a very straight or conservative approach.
Right.
We have a good technology now. We can avoid hypoglycemias. We can avoid hyperglycemias also. So if the sugar is shooting above 180, 250, we can immediately ask the patient to take whatever, and we can bring back the sugar to normal. There is a range called as 70 to to 180, which is called as a time in range. This is something which gives a fair amount of protection to the patient, especially peri-operative, especially if the patient is suffering from infection, and to get a good organ protection. 70 to 180 corresponds to HbA1c of somewhere around 7%. So this is something which we ask the patient to attain. We help the patient to attain that range.
Right.
There are a lot of people who are more health aware and they are gadget savvy. So though they are not diabetic, they may be completely healthy, but they want to check whether their glucose spikes are there. That's the trendy word which is being used.
Right.
If you really ask the academician, Dr. Erande, I don't approve of this. Why? Because if I am not a diabetic, then there is no need for me to put on a sensor and keep on chasing the sugar every 5 minutes or whatever.
Absolutely.
Okay. The flip side of the story is I can always become obsessed with the sugars, and even if I am drinking this, still I will check the sugar.
Right.
Let me see whether my sugar is going up after drinking a glass of water.
Right.
So that is not something which is advisable, because I am then likely to have malnutrition. I am like to starve.
Right.
And that's not the purpose of any monitoring. Okay.
Right.
So you should be doing a continuous glucose monitoring only under a medical advice or medical supervision.
Absolutely.
There are people who are very nicely controlled, so HbA1c is good. They are very regular as far as the follow-up is concerned, etc. But because they are health aware, because one of their colleagues has done, or maybe somebody has interacted with them, no, it's better to do that, then they also are, you can say, aligned to get all these things. But technically speaking, this is to aid better control. As I told you, avoid hypoglycemias, avoid hyperglycemias. A very important thing in type 1 diabetes, the longer the sensor wear, okay, the better is the HbA1c, lesser are the hypoglycemias, lesser are the admissions for ketoacidosis. That's a very clear-cut observation. So type 1 diabetes, depending on the patient's family affording, because the sensor costs something. All these things are important. Type 2, whenever they are having uncontrolled status, whenever they are starting on maybe, or whenever they are struggling with multiple insulin doses, we certainly take resort of CGM. And patients who are kidney problems, liver cirrhosis, old patients who are maybe likely to have hypoglycemias, we certainly are going to use CGM for these situations. Pregnancy diabetes, the ideal girl who is diabetic, pregnant, whatever variety, I will be very comfortable and I will be very scientific if I use a sensor all the time.
True.
So nowadays we have a sensor which lasts for 2 weeks, but soon we will be getting sensors which will last for 90 days, 180 days, or maybe even 1 year also. They are called as implanted sensors.
Okay.
So we will be certainly using that as soon as they are available in India. But sensors very definitely help a better sugar control, both by avoiding hypoglycemias and avoiding hyperglycemias. And they are now a standard of care for most of these situations. Keep in mind, the caveat is the patient has to be ready, the patient has to afford. They are not extremely costly, but still the patient has to bear some expenses.
True. So you have very nicely encapsulated, since last half an hour that we are talking. So passion is something, which absolutely reflects from the way you have answered and the passion for the subject itself.
Yeah.
So let me ask you something very personal, that with 35 years plus of practice, what still excites you when you get up in the morning and you are walking into your clinic?
Now the practice which I just now showed you, if I say that, okay, I am not going to maybe attend to them today, then they will call me. Okay, so the drag is always there.
Right.
I will always stick to some, you can say, some words or terminologies. So if you say that I am tightly bound to the world of diabetes or diabetic patient, that's one description. Then the other description can be that wherever am I will some tethering will be there always, which will be going on with diabetes. And then on one level, it is transcendental. So I have been, you can say, into this for 40 years. And I always see that it's not that I will be needed for maybe saving the situation, but I have to see to it that maybe some legacy is created, some good teams, some juniors. So I always get involved in different teaching fora for the same reason. And the most important thing is whatever my professor has told, Professor Ahuja, that you have to continue to be into this in different capacities till the time you can.
Very true.
So as a practitioner, as an academician, as a mentor, as a facilitator, in whatever capacity. So I write in the journals. Okay, I have very recently completed a chapter in one of our medicine textbooks, and I am writing now articles, at least 6 articles for lay people in different Diwali magazines.
Wow.
So that's something which I have to keep on doing.
Very true.
Okay,
Great.
so there is nothing like you can say now. There is no control of you can say the person over the story being finished. It will continue.
Fantastic. So that's very remarkable, and I'm sure, sir, what you're doing at this stage, where you have tremendous clinical experience and you are trying all possible ways to pass on and the legacy that you want to create.
Absolutely.
And I'm sure that all the young doctors and young people who wants to get into this field will be surely getting a lot of help from the experience that you have gained over these years. So, sir, this also brings us to a very interesting session, which is rapid fire round, which we have recently started in Azkka Virtue podcast. And I am very excited with the kind of clinical experience that you have and your contribution to the society. So this is something about myths or facts.
Yeah. Should I put on a helmet?
But I am sure this is going to be very interesting. A lot of myths will be busted with this. So with that kind of bust, I think the viewers can wear helmets. Yeah. So are you ready for this?
Yeah, please.
Okay. So, sir, does eating too much sugar cause diabetes?
Well, the answer is a very vehemental yes. I will add that simple carbohydrates. Sugar is simple carbohydrate. The more sugar you eat, there is not only a rise in the sugar, even in a normal person, but there is a rise in what is called as oxidant strain, which is a churning out of the or byproduct of the metabolism. And if you eat a lot of fructose, high corn fructose syrup is something which is very notorious as far as liver metabolism is concerned. There is a likelihood of development of fatty liver because of high fructose intake. So unchecked or uncontrolled sugar intake certainly can incite, may not be diabetes immediately, but it can certainly incite putting on more weight. Mind you, sugar today can be fat tomorrow. Because that's the way the body stores. Body has a limit of storing sugar, but body has practically no limit. Though it's a very huge limit, but it's no limit to storing fatty acids. So that's something which is to be kept in mind. And that's the reason why sugar intake or sugar consumption should be something which is to be watched for. Very important. I'll be a very interesting nugget I will immediately add. You are a human being, so you can't tolerate your ambient sugar, normal sugar, healthy sugar should be somewhere around 110, 120, give and take plus minus 20. Fasting maybe less than 100, postprandial maybe around 130, 140. Normal healthy individual. Now if you are a bird like maybe a bald eagle or maybe a falcon, then these are rapid divers. They are flying at a very huge height, maybe a couple of kilometers, and then they can still spot their prey and they dive very rapidly, pick up their prey and again go back to that extreme height. So for that they require a larger amount of sugar, which is a cache. So their ambient sugar is somewhere around 250 to 350 because they are falcons or bald eagles, not human beings. Keep that in mind.
Absolutely. You don't need to be overweight to have diabetes.
Well, yes, that's nothing can be you can say further than the truth. A typical Indian person may not be obese or even overweight by the very definition. The definition is very simple. Check your height in centimeters, subtract 100. This is for the adult. So subtract 100 and your weight in kilograms should be somewhere around that. So I am say 178 centimeters. My weight should not be more than 78. Then I will be defined as normal weight. Now, the risk of diabetes is not only depending on the overall body weight or being overweight obese, but also on the waist circumference, what is called as the central visceral obesity, which is more of a problem as far as Southeast Asia and India is concerned.
Right.
So the statement is right in that sense of the word. You don't have to be obese to be a diabetic.
Right.
But you can be centrally obese and you certainly have a very high risk of getting diabetes.
Okay.
So watch your weight, but even doubly watch your waist.
Great.
More than 90 for a man, it is overweight, you can say central obesity. More than 80 centimeters for a woman, it is higher waist circumference for the Indian people.
Okay. People with diabetes should never eat rice or mangoes.
Again, technically, yes and no. Rice is something which is, because in matters of diet, everything has to be, you can say, with pinch of salt, doubly mint. So, rice is something which can be polished. So, you go to a grocery or a supermarket and you purchase rice, mostly it is polished.
Right.
So, all the bran is gone and that rice is something which is very easily digestible. And that's the reason why consuming that rice, the digestion is relatively easy. The postprandial or post-meal sugar can suddenly rise fast.
Right.
Imagine that rice is something which is mixed with bran, or in Marathi we call it as a hatsadisa tandoor, one which is not polished.
Right.
There is a bran, so there is a huge amount of fiber. If you eat that rice, there is no fast rise of post-meal sugar. So rice is allowed with a specification.
Okay.
I advise my patients to eat rice if they can't avoid. They can eat rice with maybe a dal. So that is very important, or a green vegetable, or maybe legumes.
Right.
So varan, amti, hirvi palebhaji, usad. That if you take with your rice, there is hardly any, you can say, problem. You can eat it, no problem. The important thing is, no question should be stretched to the extent. So diet should be square diet. Some rice, some roti or bhakri, some fruits, some vegetables, all these should be mixed. So the overall balance is not one-sided.
Right.
Similarly, mango. Mango is something which we teach in JDRF, type 1 patients. They can eat mangoes or the mango juice in a measured fashion. So portion control is very important.
True.
Half a katora or a quarter of a katora, very, very important. I always tell the patients that when you are offering something sweet to the God, what you do? The size of the katora is that much. Okay, so if you are eating something which is from that katora, a very small pot or smelly fall, what is called as a very small vati in Marathi, if you use your mango or maybe whatever sweet in that quantity, you will never have a problem.
Right.
Okay, so portion control is very important.
Great. Stress and poor sleep can worsen diabetes control.
Yeah, the answer is very clear cut, yes. There is a thing called as circadian rhythm. Okay, so there is a sunlight, and when the sunlight comes, then it goes to what is called as your retina, the screen of the eye, and from the retino-hypothalamic tract, those sensations or those stimuli go to your superbrain or the control tower, which is called as a hypothalamus. Hypothalamus is a controlling tower for the endocrine system as well as for the parasympathetic and sympathetic system, which is internal nerves of your body. So there are a lot of important functions of the body which are orchestrated by the hypothalamus. Suprachiasmatic nucleus is the area of hypothalamus which is a circadian rhythm. So the body clock is what is suprachiasmatic nucleus. So you should be eating, you should be doing your physical activities only when there is a sunlight. When there is a darkness, you should not eat too much, you should not move too much, and you should technically rest.
Okay.
So the typical jungle animal lifestyle should be the lifestyle of a human being.
Right.
That was the order of the nature.
Right.
Now, busy people, for example, us, we do our 24-hour duties, intensive cares, and so on and so forth.
Right.
And our continuous glucose monitors and insulin pumps are going around the clock.
Right.
So the thing is, man has certainly evolved. So we have our own working hours, which could be eating into our melatonin hours. Melatonin is something which is a sleep hormone.
Right.
So if we work into melatonin hours, if we eat into melatonin hours, the chances of dysmetabolism or
Mm.
dysglycemia, they are very high.
Right.
So the sugars can go awry.
Mm.
There is a thing called as stress and that corticotrophin secreting hormone from the hypothalamus. So
Right.
if too much of stress is there, then there is excess amount of what is called as steroids in the body, and steroids can always move the glucose stores from the kidney, liver, muscle, etc. And they can make the insulin action a bit blunt. So the sugar will go up. Stress is something where the animal needs to have a fight or he has to survive.
Right.
So that's the steroid or stress hormone that certainly can disturb the glucose metabolism. So well, yes, sleep disturbances. I have clearly seen that a lot of our intensive care doctors, they are more likely to develop central obesity, high blood pressure, even diabetes. The shift workers, they certainly have high risk of that. All our IT people, okay,
Right.
stay in India by a body, but their work and commitment is to maybe a European office or a US office or maybe even Japan or whatever. So they have to work odd hours. They
Right.
don't sleep at night,
True.
or biological or natural night in India.
Right.
So that's the reason why sleep disturbances, stress, well, yes, very, very important as far as precipitation or development of diabetes is concerned. Mind you, that is type 2 diabetes.
Okay. Insulin is not addictive or a last resort.
Absolutely, yes. Insulin is not addictive because I have given multiple examples. We have used insulin temporarily for those girls who get pregnant. After their delivery, we stop that insulin. Operation. A lot of our patients certainly know that we have used insulin for them prior to and maybe after some days of getting out of the operation, we stop it. Then there are a lot of people where we have used insulin when the tablets are not able to contain their sugars. We have used insulin for some time. Their pancreas has got sufficient rest. Again gets refreshed. It starts manufacturing and releasing insulin. So the external or exogenous insulin is stopped. So
Right.
insulin, timely use of insulin, no long time insulin for type 2 diabetes. For type 1 diabetes, there is no manufacturing of insulin. The
Right.
beta cells are not there. So they have to use insulin lifetime.
Right. You can't live a normal life with diabetes.
This is absolutely, you can say, deviated from truth. Whatever diabetes progress which we see or claim is something to which is alleviate the lives of these people, to make their lives as, you can say, normal as possible. So the tablets, the category and the side effects of the tablets, the ultimate aims of treating diabetes, they have kept on evolving. Now we have lots of tablets which are to treat diabetes, but they don't cause low sugar. So hypoglycemia is not there at all. So somebody who is not diabetic, if we give this tablet to that guy, he will not have low sugar.
Right.
Forget about it. So that concern or worry is not there.
Right.
The same tablets can help the patient's heart pump better,
Right.
to kidney to stay longer with the patient. So they are heart and kidney protective. There are now injections
True.
once in a week, etc. They are good for sugar control. They give you a very remarkable weight loss. They improve the sugars. They protect the heart. They protect the kidney. They protect the brain from aging.
Right.
And they, you can say, in people who have sexual problems, their hypogonadism, that also can be helped.
Okay.
We have known that now these are the injections. They are called a GLP or GLP-1, GIP, etc.
Right.
So these are the ones who are not only remarkable and remarkably popular for weight loss, but they are also helpful in, you can say, de-addictions, like maybe alcohol de-addiction, smoking de-addiction. So we have now very, very, you can say, advanced kind of things which help the patient get relief from their illness, lead better lives, lead fairly normal lives.
Right.
As I am telling you, these injections are once a week. Now we are looking at once a week insulin. We are looking at such injection GLP-1s, which will be once a month.
Wow.
Sensors which are once put it today, 21st of July 2025. I will take out the sensor 21st of July 2026. No disturbance to the patient. Patient just swaps and whatever sugar graphs are there, he will be sending it to me.
Okay.
1 year.
Right.
So life is certainly going to be more comfortable. And as of now also I am telling you, patient needs to be watchful.
Mm.
He can't afford to be, you can say, now my diabetes is gone.
Right.
Don't declare that. Let me declare that. Okay, you don't
True.
declare it. Other important thing is that 3 monthly discipline, whatever checkups, not very costly, but it has to be done timely, and give a feedback to your doctor. Let the doctor take decisions. Ask your difficulties to be with your doctor. So that communication is very, very important. And the most important thing, diabetes is a silent killer. So if you don't have any complaint, don't presume that your sugars are good. Don't presume that your blood pressure is good, cholesterol is good. No.
Right.
Check it and then only say that, okay, this is normal. So far, so good.
Right.
That's the principle. And then we have a lot of people who are staying with diabetes for more than 40 years, more than 50 years. One of our esteemed teachers, Professor Mohan from Chennai, he has practically, if I am not wrong, more than 100 people. And he has a club which is called as a nonagenarian. So they are 90 plus.
Right.
So just imagine that with a good, you can say, discipline, you can have not only a normal life with diabetes, but you can live a, you can say, normal lifespan also.
True.
Very, very important.
Very true. Great. So last but not the least, diabetes is not just about sugar, it's a whole body condition.
Absolutely. In the flow of discussion, I have always repeated the philosophy of ABC, HbA1c, blood pressure, cholesterol. These are the standard accompanying cousins, so to say, of diabetes. So we have to be aware of that. Professor Tedros Adhanom Ghebreyesus, our esteemed WHO chairman, he has written a compendium called as Chasing a Silent Killer. That pertains to hypertension. And the same you can say about diabetes. So diabetes is a silent killer. It is not only a sugar, it is defined by sugar, but it expresses through the circulatory system, heart circulation, brain circulation, so heart attacks, paralysis, leg circulation, so amputations because of gangrenes, kidney problems, retina and the blindness problems, infections. Lot of, you can say, uncontrolled diabetic patients, especially in India, they are more likely to have tuberculosis, fungal, lot of other infections. So we don't want these to be expressed through different things. Concentrate on sugar, but be aware of the rest of the things also. Fatty liver never to be forgotten. And the most single, you can say, line advice to the patients, let your doctor decide whatever about your health. Let the doctor decide it. Don't take any decision on your own, you can say, right, or on your own power. Be in, you can say
that this is so nicely encapsulated, and I'm sure all the viewers at large will get a lot of insights.
Hope so. Yeah.
So I'm very sure, and your passion for the subject actually was very reflective in this conversation. So, sir, you have taken us, today beyond treatment protocols in the real evolving world of diabetes care. Thank you for sharing
Thank you so much. Thank you.
your clinical wisdom, your lifelong commitment to patient education, and for reminding us that chronic care is as much about precision as it is about people. So we are honored to have you on the Azkka Virtue podcast. Until next time, stay informed, stay compassionate, and keep redefining care. Thank you so much.
God be with you.
Thank you so much.